As you join, please keep your microphones on mute. If you have questions, please post it on chat box. Once we finish the talk, we'll take each question at the end of the talk from the chat box. This is just to avoid any kind of cross-talk in between. So thank you for joining once again. And I would request Nitin, and Nitin needs no introduction, to go ahead and start his talk. Nitin, you can share your screen now.
Sure. Give me 1 second.
Hello.
Nitin, we can see your screen. You can just go on full screen mode.
Yeah, I think I'm, give me a second. I'm just trying to swap. Give me just 1 second here.
Please take your time.
Sorry, just give me a second. What happened here?
Slides were there, Nitin.
Yeah. Actually, no, no slides are there. Sorry.
You just need to go to screen mode. That's all. Yeah. You just. Yeah.
Okay, you see it
You're
now?
good to go. Yeah, absolutely. Fine. Perfect. We can hear you clearly.
Okay, perfect. So good morning, everyone. And thank you for coming so early for this talk. It's late evening here in Houston, USA. So first of all, just want to hope that everyone is doing safe and doing the best they can in the COVID era. And hopefully things in India will continue to improve as time goes by. So the focus today is to really specifically talk about CLL. So maybe in the next 30, 35 minutes or so, I will talk about the management of CLL. And really it will largely be on the perspective of what we are doing in the United States with the FDA approval of different drugs. At the same time, towards the end, I will briefly talk in few slides about the COVID-19 and at least in the management of CLL, or at least what we have been doing here or thinking of doing here. So with that background, these are my financial disclosures. As you all very well know, that the treatment of CLL has changed quite remarkably. And certainly this is an exciting era to be a clinical investigator in the field of CLL. As is shown in this slide, the therapy options really took a big jump initially in early 2000s, so with the use of rituximab with chemotherapy, so chemoimmunotherapy, FCR, bendamustine rituximab, drugs such as alemtuzumab, lenalidomide were also tried at that time, but really have not been developed subsequently for CLL. But the major really era changed back in 2014 when we had first ibrutinib approval, and then subsequently we have now acalabrutinib approved. We have two PI3 kinase inhibitors approved, BCL2 inhibitor venetoclax, and then we have novel CD20 antibodies such as obinutuzumab, and all these has been in the last 5-6 years. So really this has been a remarkable opportunity, and when I joined MD Anderson back in 2012 as a faculty, this is what the field of CLL was kind of exploding, and all these drugs were kind of coming along in the pipeline, and that's what I decided to focus on CLL. So this is the treatment paradigm, I think, which has changed based on what I just told you. I think up until a few years ago, at least in the United States, the plan was, or the regimen was to give FCR for young fit patients. And then for older patients, the choice was between bendamustine rituximab or chlorambucil based therapy, with the caveat that many young patients in the United States were also getting bendamustine rituximab just because it's less myelosuppression than FCR. And now what would be call a target therapy era, I think in my opinion, FCR should really be reserved for young fit patients who are IGVH mutated, and we'll go over the data which supports that observation. And then for all other patients, in my opinion, target therapy should be used. This is the schema, I would say, at least in our practice here for patients with CLL. And what you see here, that if a patient is treatment naive CLL, and kind of you can go down the list depending on if they have deletion 17p or p53 mutation, if the patient is young or old, if they have major comorbidities, and especially in the younger patients if they have IGVH mutated or unmutated. But what I would like to highlight is that if you look for FCR, the only chemoimmunotherapy listed in this slide is the bottom left corner, which is FCR. And if you go back, so really the FCR is reserved from IGVH mutated patients, young patients without major comorbidities, and obviously without any p53 aberration. Rest all patients, at least in my opinion, should be receiving target therapies. At least in the United States, 3 target therapies are approved in the frontline setting: ibrutinib, acalabrutinib, and venetoclax. And again, we will focus them in this talk. In the relapsed refractory setting, we also have PI3 kinase inhibitors. But in the interest of time, today I'm not going to talk about relapsed refractory CLL, but certainly if there are questions, I can address that. But I will really focus on treatment naive CLL for this presentation. So let's discuss these patients one by one. So let's first talk about young fit patients. So these are the patients who are, I would say, are FCR eligible patients. So the story for FCR, the first study was led by Dr. Michael Keating here in our group, which was reported now 15 years ago in this paper, where the first 300 patients were treated. And what you see here, the very high response rates, 72% complete response rate, 95% overall response rate. And that really made FCR kind of one of the promising regimens for patients with CLL. This was subsequently taken up by the German CLL study group, and they compared head-to-head FCR versus bendamustine rituximab. Again, this was pre-ibrutinib era, to say, before the target therapies. And what you clearly see here is that for young patients with CLL, FCR leads to better progression-free survival versus bendamustine rituximab, with the caveat that there is more myelosuppression with FCR, there were more infections with FCR. But if your goal is for a patient to achieve prolonged progression-free survival, certainly FCR was better than bendamustine rituximab, and this was the primary endpoint of the study. So this study really established FCR, at least at that time, as the standard therapy for young patients with CLL. What has changed? So more recently, in the last, I would say 1 year, we heard the results of the ECOG 1912 trial. So what was this trial? So this trial was originally reported at ASH 2018 and was updated this past year, ASH 2019. So this is the updated data slides from the ASH 2019. What the investigator did, and I think this was a very nice study in my opinion, was young fit patients. They said, okay, FCR is the frontline therapy we know. Why don't we compare FCR head-to-head with ibrutinib rituximab? So patients received standard 6 cycles of FCR, and on the other arm, they received ibrutinib rituximab, followed by continuous ibrutinib, as it would do till disease progression or significant toxicities. And this study now was reported with a median follow-up of 4 years. And the primary endpoint here was progression-free survival. So these were the updated curves from ASH meeting. What you see here, the top line, the red line here is ibrutinib rituximab, the bottom line here is FCR. So quite clearly, therapy with ibrutinib is superior to FCR for progression-free survival. So that's a quite remarkable strategy where you have a target therapy in the frontline setting going against a very standard comparator, really a standard chemoimmunotherapy FCR comparator, and showing superiority for progression-free survival. When they looked further into which subgroup of patients derive the most benefit, what they noted was that IGVH status seemed to be very important. What you see here, if you look at the IGVH unmutated curve, which is the curve on the right side of the figure here, you see a clear demarcation between unmutated and mutated. And ibrutinib rituximab is really superior to FCR. On the flip side, if you look at the curve on the left side, where the top arm is still the ibrutinib and the bottom, the dashed black line is FCR. But clearly the curves are not separating very much. The p-value was not significant at this time of this follow-up. So this led to this conclusion that, or at least this is how the thinking has evolved, that certainly for unmutated patients with IGVH, we should not be doing chemoimmunotherapy because you really see a nice separation of PFS curves. At the same time, for IGVH mutated patients, and given that we know FCR can lead to long-term disease-free progression-free survival, and I will show you some data to that effect, that FCR is still an appropriate therapy for IGVH mutated patients. And that's one of the reasons of making this distinction. And I think this study provided that argument that for unmutated patient, we should move away from chemoimmunotherapy. Another important and unexpected finding, I should say, was that there was an overall survival benefit for ibrutinib arm versus FCR arm. The numbers are small. The number of deaths actually are small in both the groups, relatively speaking, but they were able to show a statistically significant OS benefit for ibrutinib. Now, I should mention that most of the deaths in the ibrutinib arm actually occurred in patients with unmutated, most of the death in the FCR arm occurred in patients with unmutated V gene. So again, the unmutated V gene seems to do less well than mutated V gene. Now, just to kind of brief segue what we are doing at MD Anderson for this group of patients, I mentioned to you just now that in our experience, which has been now replicated and confirmed by many other groups, IGVH status seems to play a very important role in terms of long-term outcomes after FCR. So this is a very long-term follow-up data reported by Phil Thompson from our group. And what you see here, the axis here at the bottom shows up to 16 years of follow-up. So, but the median follow-up was around 10, 11 years. But you clearly see that the top curve, which is the IGVH mutated curve, after around 8 to 9 years, practically the curve is a flat, it's a plateau. And what you could argue is that these are the patients, approximately 55% or so, who got 6 cycles of FCR 10 plus years ago, and they're alive in remission, 10 plus years down the line, making this argument that these patients may be considered cured of their disease at this time. And we argued, now this goes back to 2014, 2015, that this is the group of patients which is chemosensitive, and maybe we can devise or design some chemoimmunotherapy combination for this group of patients to make their outcomes even better. So a regimen we have developed here at MD Anderson, which we actually updated this past ASH meeting, is a regimen we call IFCG, ibrutinib, fludarabine, cyclophosphamide, and obinutuzumab. And this was a regimen, the treatment is only for patients with IGVH mutated CLL without P53 mutation or deletion 17p. So we are taking a good group of patients who do really better with FCR, and our hypothesis is that can we hopefully make the treatment even better. So there were a few changes we did from standard FCR in this regimen. So first of all, we replaced rituximab with obinutuzumab because that leads to higher MRD. UMRD, which is shown in this slide here, refers to undetectable MRD, which is kind of a new terminology which is being used for MRD negative patients. We also added ibrutinib in this regimen for a time period of 1 year, and I will explain to that in the next slides. And then an important aspect was that we changed the number of chemotherapy cycles from 6 to 3. So no patient is getting 6 cycles of FCR or FC. The maximum is only 3 cycles. So this was a study at MD Anderson. Again, a very focused study for IGVH mutated patients only. And we call this IFCG because of the GA101, which was the original name for obinutuzumab. So this was a study schema. Basically, patients get 3 cycles of IFCG. After that, they have a response assessment. And then they get 9 courses of ibrutinib or 3 or 9 courses of obinutuzumab, depending on the MRD status. But notably, no patient is getting more than 3 cycles of chemo. And as I mentioned, at 12-month mark, if they are MRD negative in the bone marrow, patients will also stop ibrutinib. Because what we didn't want to do is develop a regimen where patients will keep taking ibrutinib for the rest of their life. We wanted to have a time-limited regimen for these patients. That's what we argued, and probably this is one of the first studies where ibrutinib was proactively being discontinued for MRD negative remission. These were the first 45 patients we have treated. And again, just want to highlight here that if you look at the disease characteristics, everything is favorable because this is actually a favorable group of patients we are trying to treat in this study. Now, these are the best responses on the study on an intent to treat analysis. So we had 45 patients enrolled, and 44 out of 45 patients achieved bone marrow undetectable MRD, so MRD negative remission in the bone marrow with a sensitivity of 10 to the power minus 4. So that's a very high rates of remission, possibly in any CLL study reported so far. Now, question you may be thinking is that is all and good, but how does that compare to FCR? That's what we all are more familiar with. So in this particular slide, what I note here, this is only slide for patients who receive, who are IGVH mutated, who have a bone marrow MRD done after 6 cycles. And what you see here, all the prior trials from MD Anderson, the trials from CLL study group, FCR, receiving FCR6. There was a green study in which FC was combined with obinutuzumab for 6 cycles. And Matt Davids at Dana-Farber recently reported ibrutinib FCR, where patients get a standard 6 cycles of FCR, and then they also add ibrutinib on top of it. And the bottom is the IFCG regimen I just mentioned to you, where you only get 3 cycles of chemotherapy, and then followed by 1 year of total of 1 year of ibrutinib obinutuzumab. But if you look at the 6 cycles outcome for these patients, what is clear is from this bone marrow MRD is that the IFCG regimen was able to achieve very high rates of MRD negativity for our patients, despite being the only regimen using 50% less chemotherapy than the standard 6 cycles FCR. So we think this is a very potent regimen for our patients, and we are able to do that with 50% less chemotherapy. This is the progression-free and overall survival curve. Obviously looks quite great. Again, this is CLL patients, so we don't see that much dropout early on. But I just want to highlight here that if you look at FCR at 3 year, if you look at the ECOG study or the CLL10 study, at 3 year PFS from FCR for mutated patients is around 82%. So this survival curve certainly looks better, but again, this is a small number of patients at a single center. Moving on, so the most largest group of patients you will see in your practice actually is older patients. So these are the patients who really cannot receive chemoimmunotherapy. These are patients in their 60s, 70s, 80 years of age. And really that's the majority of patients with CLL we see in our practice, and I'm sure you see in your practice. So for older patients, lots of work has been done. So one of the important study to mention here will be the study called RESONATE-2 study, where older patients were randomized in the frontline setting to ibrutinib versus chlorambucil. There was no CD20 antibody in this trial. And what you see here, this is a recent update, 5-year update of the data, that at 5-year mark with single agent ibrutinib, the 5-year PFS is 70%. And I would say obviously much better than chlorambucil monotherapy, but again, at least in the United States, chlorambucil is hardly ever used for patients with CLL. But certainly ibrutinib is showing a remarkable benefit here. And I think this 5-year 70% is something to remember maybe, and this is something many times when patient ask me about the expected remission duration. So this is the number I tell them these days, that if we do frontline ibrutinib, approximately 5 years PFS is 70%. Now what has happened, this is the same study, just looking at the mutation and ours is unmutated. Both the groups are doing equally well. It was a bit intriguing to me, if you see it towards the tail of the curve for the ibrutinib mutated versus unmutated, there may be a small separation there, but again, small number of patients, hard to say. But nonetheless, unmutated is doing very similar to mutated patients with ibrutinib. And this study also showed an overall survival benefit in favor of ibrutinib versus chlorambucil. Again, there is no CD20 antibody here, but again, head to head, at least with chlorambucil, there was an OS benefit. Now, another major study, which was actually plenary abstract a couple of years ago, was reported by Jen Voyak for the Alliance group, where again, they took the older patients and they argued that let's compare them to a very standard chemoimmunotherapy for older patients, which is bendamustine rituximab. So I think this study was very, very interesting design, and I think it helped answer a few questions for us. So the first question the investigators are going to ask was that whether bendamustine rituximab, which is a very standard frontline regimen for patients with CLL, how does that compare to ibrutinib? And the second question they wanted to answer was that, do we really need a CD20 antibody rituximab with ibrutinib? So the study had three arms: bendamustine rituximab, ibrutinib alone, or ibrutinib plus rituximab. And the primary endpoint was progression-free survival. So these are the curves which were subsequently reported in New England Journal. And what you see here, the bottom, the black line is the bendamustine rituximab. And the two top curves are ibrutinib. One is with rituximab, one is without rituximab. So a couple of points are clearly shown here that if you are going to use bendamustine rituximab for your patients, here using ibrutinib in the frontline setting, you're getting an improved progression-free survival. Second point here is that there is no benefit of adding rituximab over ibrutinib. So in our practice here, we use just single agent ibrutinib. We don't combine it with CD20 antibody. I should mention here that there was no overall survival benefit in this study. So I think that leaves that possibility that someone could say that, hey, why don't we do bendamustine first? And if the patient were to relapse, I can go back to ibrutinib. I think that's a reasonable strategy because there is no OS benefit in this study. At least in the United States, I think given insurance for the drugs and things like that, I think most people, clinicians have moved away from chemotherapy or moving away from chemotherapy in favor of targeted therapies. Another very important abstract, which was reported at this past ASH meeting and recently published in Lancet, was the Elevate TN study reported by Jeff Sharman. So this was also a study for older patients. Now, just to kind of remind you, acalabrutinib is a second generation of BTK inhibitor. It is like ibrutinib in the sense that it binds C481S site of the BTK, but it is more selective for BTK compared to ibrutinib. And therefore, the safety profile is a bit different, and we'll discuss briefly as I showed you the data, for this study. So this study also was quite interestingly in terms of the design. Here, older patients were randomized to acalabrutinib plus obinutuzumab, acalabrutinib alone, or chlorambucil plus obinutuzumab. So chlorambucil obinutuzumab obviously is kind of a control arm, and this is the PFS results at 2 years. And what you clearly see is that the bottom line, the bottom curve, 47% is chlorambucil obinutuzumab. So let's disregard that because that's not really important here. But what you see here, the top two curves are the acalabrutinib. And the one which is 93% is acalabrutinib obinutuzumab. The one which is 87% is acalabrutinib alone. So both the arms are obviously superior to chlorambucil. And there is a 6 percentage point PFS difference by the addition of obinutuzumab. And it was actually, if you look at the hazard ratio on the table on the right side of the slide, the hazard ratio was 0.49, and it was not crossing 1, so it is a statistically significant hazard ratio. So one could argue, based on this, that acalabrutinib plus obinutuzumab is actually statistically superior to acalabrutinib alone. Based on this, actually, the FDA approved label in the United States is acalabrutinib with and without obinutuzumab. However, I would say that in our practice, we are not combining obinutuzumab with acalabrutinib yet. And the reason for this is kind of what's here, where one of the slides, I think, the reason is that the risk of neutropenia with acalabrutinib obinutuzumab is around 30% versus around 10% with acalabrutinib alone. So Though there is a small PFS difference, which I don't even know if it will hold up with further follow-up of the study, but you're certainly going to increase the risk of neutropenia. Obviously, with obinutuzumab, you have to give the infusion, IV, infusion reactions with obinutuzumab. So based on all that, at least in our practice, if we are using a acalabrutinib, which we are, I use a acalabrutinib single agent. Now, in this slide are clinical interest of adverse events of special interest, and where what's specifically highlighted is atrial fibrillation. So as you probably well aware, with ibrutinib, atrial fibrillation is quite common and actually has been described now up to 10 to 15% of patients may develop atrial fibrillation. In the study, at the time of this analysis, it was kind of close to 4%, 3 to 4% range. There's a general perception that, at least in the investigators who have used this drug, that the risk of AFib is certainly lower than ibrutinib, and that's what my practice has been. Now, there is a head-to-head trial of acalabrutinib versus ibrutinib in the relapsed refractory CLL, which we are all kind of waiting results. And I think that trial will help kind of clear this argument one way or the other about the safety profile and efficacy of these two BTK inhibitors. So this all is actually excellent news for our patients, right? I showed you that with ibrutinib, patients are really having impressive progression-free survival. We also saw early data with the acalabrutinib kind of mimicking the same. But the problem, I think, with BTK inhibitors has been it's an indefinite therapy. You have to take it for life. Certainly in the situation in India, the cost will be a big consideration here. And the CR rate is low, and MRD, undetectable MRD is practically non-existent with these agents when used as single agent. And where the field is moving is that to develop time-limited therapy, time-limited combination therapy of these targeted agents, which we can stop in 1 to 2 years. So in this regard, one of the first and important regimen which is being developed is called CLL14. It is actually already FDA approved, which was done by the German CLL study group. And here, patients were randomized, older patients were randomized to receive venetoclax obinutuzumab for a total of 1 year versus chlorambucil obinutuzumab. This is an updated slide from ASH this past year, where what you see here with venetoclax obinutuzumab, the 3-year PFS is 82%. The bottom curve is the chlorambucil obinutuzumab. Now, what you have to realize here is that here, all patients have actually stopped therapy at 1 year mark. So after 1 year of this study, all this PFS curve you see is actually just on observation. These patients are not getting any therapy at that time. Unlike the BTK curves you saw before, where actually everyone on those curves were still taking BTK inhibitor, whether ibrutinib or acalabrutinib, up until they progress. One of the things to kind of highlight, which was, I think, a new observation at the ASH meeting, was that the investigators also showed breakup of responses by p53 status. And to me, what was a bit concerning, and maybe it's a small number of patients, is the responses of p53 deleted or mutated patients to obinutuzumab. And you see that the numbers are small, but you see this curve is kind of dropping pretty quickly after the patients have stopped therapy at 1 year mark. So I think it's important to kind of see how this pans out with longer follow-up and maybe some additional studies looking at this specific subgroup of patients. But this kind of maybe make me kind of pause and think about it for my patients, that whether it is an appropriate therapy, a time-limited therapy is appropriate for del17p p53 mutated, because here patients seems to be relapsing after they are stopping therapy at 1 year mark. What is true about venetoclax obinutuzumab is it does lead to very high rates of blood and marrow MRD negative remission, as is kind of highlighted in the red here. At the same time, what you have to remember is that if you're going to use venetoclax obinutuzumab in your practice, half of the patient actually will develop grade 3 or 4 neutropenia. So these are the patients you have to be really careful about blood count check and giving them growth factor, GCSF, or many times dose reductions for venetoclax. So I thought for kind of academic exercise here, let's compare the curves of two kind of our frontline regimens and see how they fare. So we are advised not to do cross-trial comparison, but it's always fun to kind of look around. So here on the left side is venetoclax obinutuzumab CLL14 data I just showed you. And then on the right side is the RESONATE-2, the ibrutinib data I just showed you. And it's quite interesting is that if you look at the 3-year PFS, which is the longest follow-up we have for the venetoclax study, actually the 3-year PFS is exactly the same if you plot them as is plotted here of 82% for these patients. And then despite the fact here, I could argue that in the venetoclax study, actually the patients are stopping therapy at 1-year mark. And despite that, they're able to match the PFS of ibrutinib. So now it remains to be seen what will happen with the venetoclax G study with longer follow-up. The maximum we have is 3-year. What will happen at 5-year follow-up? That's something we don't know. And at least here in our practice here, it's a common questions for the patient and discussion now that we have 3 frontline approaches, ibrutinib, acalabrutinib, and venetoclax obinutuzumab. And this is the discussion I quite frequently have with patients when I'm discussing the options with them. What are the pros and cons of different approaches? So certainly with ibrutinib, we have a longer follow-up for this study because this was the first BTK inhibitor. The problem with ibrutinib is its indefinite therapy, low rates of remission, and then atrial fibrillation and bleeding issues. Now, with acalabrutinib, we have certainly reduced off-target effects, which may translate into better safety profile. Again, the con is very similar to ibrutinib. And with the obinutuzumab, the advantage, really the big advantage is it's a time-limited therapy. But we have a shorter follow-up. We don't know what will happen 5 years down the line. Tumor lysis syndrome, something we need to watch for, and you have to kind of monitor the patients. Obinutuzumab is certainly IV drug. And then neutropenia, as I said, half of the patients would develop neutropenia. So very quickly, I think we may be running out of time. So I'm going to do kind of very quick here. What at MD Anderson, we have kind of invested quite heavily on this combination of ibrutinib plus venetoclax for our patients, given that this is 2 oral drugs together. And there was a preclinical rationale to combine the 2 based on the lab from Varsha Gandhi in our group. So we did a study, which is an ongoing study actually, of combining ibrutinib plus venetoclax, 2 oral drugs for frontline therapy for patients with CLL. So this was a frontline high-risk patient. So deletion 17p, deletion 11q, unmutated V gene, or age above 65 years of age. Patients get 3 months of ibrutinib, followed by addition of venetoclax for a total of 2 years of combination therapy. We actually, in the entire study, we have now treated 200 patients at our center. We reported the data for the first 80 patients on the frontline cohort. And where what you see here, this is a high-risk patient population because we purposely selected high-risk patients. And at the bottom of the slide, you can see that 92% of these patients had one of the high-risk features for chemotherapy, unmutated V gene, p53 aberration, or deletion 11q. We reported these results last year in New England Journal, where at that time of follow-up, at 1 year mark, we had 61% of the patients achieving MRD negative remission. We updated the data at the ASH meeting, where just want to highlight one part here, that if you look at the 80 patients we had, as a best response, which is listed in the bracket, the top on the curve, 60 out of 80 patients, so 75% of the patients achieved bone marrow MRD negative remission as their best response with 2 oral drugs. So that was quite remarkable to achieve with 2 oral agents. It was also very gratifying to see the Captivate study, which was a large international multi-center study reported by Contam, also at the ASH meeting, which has a very similar design to the study from MD Anderson I just showed you, where also patients get ibrutinib for 3 months, followed by ibrutinib plus venetoclax for 1 year. That's the cohort they reported. And it was really nice to see that in their analysis as well, approximately 72% of the patients achieved bone marrow MRD negativity. So our study had around the similar number. So it's fair to say that with this combination, approximately three-fourths of the patients will achieve bone marrow MRD negative remission, which is actually a very high number in my opinion, and very nice to see that our single center study results were actually very similar to this multi-center international study. And the field of CLL continues to evolve. And I just show here some of the frontline phase 3 studies which are ongoing. I won't go through them in detail, but just want to give you a flavor here that there are a large number of studies happening with multiple different treatment arms, investigational treatment arms, looking at different combinations with ibrutinib, with venetoclax, with acalabrutinib, also multiple combinations like you see here, venetoclax, ibrutinib plus obinutuzumab together. So in the next 1 to 2 years, we should start seeing some early data from these studies. And I think this will further help define how we treat our patients with CLL. So unanswered questions in the field. What is the ideal frontline combination? Is it a BCL2 inhibitor combined with C20 antibody or with a BTK inhibitor? Or should we do a triplet with all three together, or maybe it's something else? How much is the ideal treatment duration? It's a big question in the field. CLL14 is a 1-year study. Venobinituzumab, I mean. Venetoclax ibrutinib studies, we have done a 2-year study. Other groups are doing 1-year study. A UK group is doing MRD-based study of treatment discontinuation. So it remains to be seen. And in the relapsed refractory CLL, though we didn't talk about it in the interest of time, there's a lot of new BTK inhibitors coming in the pipeline. And there's also CAR-T, which is actually turning out to be a very good approach for multiply relapsed refractory patients with CLL. And again, something, at least in the United States, and we're kind of looking forward into it. Now, that completes the CLL part. Now, in the next maybe 3 or 4 slides, I was also asked to quickly talk about COVID and CLL specifically. So this is going to be a very general few slides to say. So I would just say that if you, for CLL patients specifically, and some of these recommendations I would say are general recommendations, nothing really specific for CLL. I would say that so far, yes, there are some reports coming up in the literature for a few patients here and there with CLL, but I don't think there's any large scale data yet. At our center, I have a total of 4 patients of mine who with CLL who developed COVID-19, and all of them actually have recovered and have done fine. I think there's a general perception that because of immunosuppression, CLL patients are at a higher risk of severe complications. Again, that's nothing proven yet. And certainly lockdown, social distancing, I think that's what has been happening here and obviously in India. I think one of the things we have done in our practice, which again is true, I think for most places, is that if patients with CLL who are just on observation, we are trying to avoid unnecessary clinic visits, a lot more use of phone calls, telemedicine, and really, there is no reason for these patients to come to the med center just for checking every 3 months or 6 months follow-up. As long as they are doing clinically fine, they can stay at home. For patients who are about to start therapy, most of the time patients with CLL, there is no urgent need to start therapy that very day. Obviously, there are exceptions to the rule. And I have deferred therapy back in March. There were a few patients who were about to start therapy, and I told them to come like in May. So now they're actually coming to us to start therapy for their CLL. So I think certainly the therapy could be deferred if possible. And I think, again, the general thinking is that we should prefer non-myelosuppressive therapy, so stay away from FCR or chemoimmunotherapy, at least at this time frame, at least at the COVID time. Patients who are on active therapy, we are not changing any plans. If the patient is on ibrutinib, patient is on venetoclax or acalabrutinib, certainly they keep taking those drugs. We do try to limit the hospital and clinic visits, and certainly we are actually in our practice, we are now trying to do more of video visits with the FaceTime and Zoom actually with the patient. And that's kind of now becoming something ingrained in our practice. And maybe this is actually my second to last slide. And patients who develop COVID, I think that's obviously a totally different kind of topic. At least the few patients I have in my practice, they were actually all on ibrutinib at that time. So we held the ibrutinib in the acute phase as they were getting treatment for their COVID-19. The rationale for that was that there was a concern about ibrutinib and possible AFib and ventricular arrhythmias. Though at the same time, as you may know, ibrutinib, acalabrutinib, and some other BTK inhibitors are actually now being studied actively for CRS associated with COVID-19, irrespective of the CLL. These are just global trials which are running. So we'll see how they pan out. So with this, I would like to conclude. This is my email address. If you have any questions later, certainly you can email me. I will be happy to answer. Thank you, everyone.
Thank you, Nitin. That was really a wonderful talk. I think Dinesh could not join because he was having some issues with the hospital and the network. I'm not sure whether he's here now. Dinesh, you're on. Yeah, great. So, yeah, thank you, Dinesh. So do you want to start taking up the questions on the chat and moderate this session?
Access to the questions, or you want me to take it?
Dinesh, if you want to take up the questions on the chat box, you can start with that, unless you have some questions from your own end.
Okay, let me try. You can take the questions, if you don't mind, Manju.
Yes, sure, Dinesh. So, yeah. So, Nitin, the first question is, let's say if the young patient has been started on FCR, the IGVH mutation report is not yet available. And after 1 to 2 cycles, it turns out that he's IGVH unmutated. Would you change to ibrutinib?
Well, I mean, I think if you have already started FCR, I may finish 3 cycles. There was a data from our group published by Paolo Strati in Blood 2014 that patients who get 3 cycles of FCR, and we had MRD assessment for these patients. So this was the original FCR study. Patients were supposed to get 6 cycles of FCR, but some patients had stopped after 3 cycles for whatever reason that might be. And we had a bone marrow MRD assessment at that time. And in a retrospective analysis to that study, if you are MRD negative at after 3 cycles of FCR, there was no incremental benefit in PFS for additional 3 cycles of FCR. So I think if this particular patient, rather than switching to ibrutinib, to be honest with you, I think if you have given a couple of cycles, I may do 1 more cycle and maybe just sit tight. I mean, patients may do well for a long time before actually you need to go back to ibrutinib. So I would not proactively change to ibrutinib unless the disease is progressing or something like that.
So just a corollary from the same questions. If you look at the data where ibrutinib was combined with rituximab in the ECOG trial and compared with bendamustine rituximab, the ibrutinib rituximab did not do any better than ibrutinib. So what is your comment in this trial of FCR versus IR, whether rituximab is adding anything there or it's just the ibrutinib which can be continued?
Yeah, so I mean, I think I hope and I wish that the FCR study, the ECOG study was designed FCR versus ibrutinib rituximab versus ibrutinib alone. I wish they had an ibrutinib alone arm, but they didn't. So because of that, the data on the young patient is only with ibrutinib plus rituximab. However, I think most of us are extrapolating the data from the older patients, the Alliance trial, where there was a randomization and there was no benefit. And also there was a study at MD Anderson, which Jan Berger reported, I think in Blood, was that in relapsed patient also ibrutinib versus ibrutinib rituximab, we had a 200 patient randomized study. There was no benefit of adding rituximab. So I think we all are extrapolating these 2 data sets to younger patient as well. So in our practice, if I'm going to use, even for a young patient, ibrutinib, I'm using ibrutinib alone. I'm not combining it with rituximab, though you're correct that the data we have from the ECOG trial is with rituximab.
Thank you. So just coming, taking further on that same subset of patients where we've started on ibrutinib as IGVH unmutated. We are going to continue it for a long period of time. These are young patients. Suppose they fail ibrutinib down the line. Do we have an option of switching back to FCR, or we have to start looking at the other newer agents?
So certainly there is no data out there of FCR, prospective data, I should say. I think in the most of the clinical trial, actually chemotherapy has practically vanished from relapsed CLL's phase. No one is testing chemotherapy. And even in the frontline setting, besides our study, there are only the IFCG study, our study, there are only few other centers doing some chemo and immunotherapy-based trials. So I think if a patient had a progression, has a frontline ibrutinib, they have progressed on frontline ibrutinib, I think certainly if they do not have deletion 17p, maybe if they have a mutated IGVH, if you want to go to FCR because venetoclax is going to be quite expensive, I think that's fair. I think, again, there's no data to support that, but you would expect that you will see some activity certainly of FCR in that patient subset, especially if they are del 17p negative and IGVH mutated. I think if they're IGVH, if they are del 17p positive or p53 mutated, then I really think FCR is not going to do much. And in that case, you should really use
There will be higher
prefer
chances of
venetoclax.
patients with the once you relapse post ibrutinib, it will be a more T53, more 17p, so less likely to be the FCR working there.
Well, I mean, it's a fair point. I don't know. I mean, certainly we know that patients who relapse after FCR, they gain, because chemotherapy, you select for a p53 clone. That certainly has not been described with ibrutinib, that you gain p53 mutation after. I mean, you have a BTK mutation, which is a resistance mechanism to ibrutinib, but I don't know if gain of a p53 mutation has been described. So, but it's quite possible that you started the patient on ibrutinib at the first place because the patient was a del 17p patient, because that's where the first approval of ibrutinib was, and that's where that likely is a scenario you're referring to.
So the next question on the chat is regarding the IFCG protocol. So the concern is we are adding all 4 drugs. So are we adding up too many side effects, and whether it's suitable for all young patients? So I think what they wanted to ask, what's the A's and SA's with this 4 drug combination?
Yeah, so it's a very valid question, and sorry, in the interest of time, I didn't show the AE is SAE, but it's in the ASH abstract or ASH presentation, and I'm happy to email the slides if anyone were to reach out to me on email. We certainly saw increased neutropenia. Initially in this IFCG study, we did not require GCSF support, prophylactic Neulasta or Neupogen. I'm not sure in India, GCSF. We did not mandate it. And the grade 3 or 4 neutropenia was close to 60%, 65%. After patient 30, we mandated GCSF. So first 3 cycles after 3 days of FC, the 4th day they get GCSF Neulasta. And since then, we have cut down on the neutropenia risk. So neutropenia was the main risk. The neutropenic fever, we had 4 patients with neutropenic fever out of 45 patients. And if you look at these numbers and compare it to what has been reported with FCR in journal, if you look at the CLL10 trial, they are very similar in terms of the rate of neutropenia, in terms of the neutropenic fever. We did see atrial fibrillation in around 10% of the patient, which again would be because it's coming from ibrutinib, obviously. So that's something is new, which certainly would not have happened. But what I showed was the depth of remission with these patients was actually quite high compared to standard 6 cycles FCR. So certainly there is some increased toxicity profile, but there were no obviously deaths in the study from toxicity for these patients.
The next question is, what's your view on ibrutinib intolerance, and what percentage of patients will go on for drug discontinuation and dose reduction? And how would you differentiate between acalabrutinib and ibrutinib based on your clinical experience?
So certainly I think ibrutinib, we have used quite commonly ibrutinib in our center. I think we have close to 1,000 patients now with ibrutinib treated at our center. So ibrutinib, I would say 20 to 30% of the patients in my practice are on a lower doses of ibrutinib than the standard dose because of the side effects, most commonly arthralgias, some bleeding issues, atrial fibrillation. So that's a substantial number, I would say, and that has what has been described actually in real-world studies of ibrutinib by Anthony Mado as well, up to half of the patients having dose reductions and with ibrutinib. Now, in terms of acalabrutinib, so certainly there is data out there, as you may have seen, that patients who had intolerance to ibrutinib, there was a study, prospective study designed, where they were switched to acalabrutinib. And then most of the patients their AE profile improved, their side effects improved, and they were able to tolerate acalabrutinib better than what they were doing with ibrutinib. So that certainly, I think, is a very important data set. in my practice, I think the question was also in my clinical experience. So in my clinical experience, acalabrutinib actually appears to be safer. I don't have a lot of patients with acala, maybe, I don't know, 15 patients maybe. With acala compared to ibrutinib, we have several hundred. But again, in that patient population so far, headache I have seen in some patients, which is a well-described side effect with acala. But other than that, maybe one patient I had to decrease the dose of acalabrutinib, but practically everyone else is on the full dose 100 BID with no real issues. So that's, I think, real distinction about these two drugs will come along when we have the randomized study of acala versus ibrutinib reported.
Is there any study with the lower doses of ibrutinib starting in the front line?
We had reported a very small pilot study. There are some efforts actually we have been involved in. I can tell you it's kind of some of those efforts have stalled now because of the COVID-19 and some other issues. So as far as I know, no one is looking at lower doses of ibrutinib prospectively for patients with CLL. But there were some efforts we were involved in, but right now it's not being pursued actively.
The question is, based on CLL14 data, do you think that the high-risk group of CLL should continue to receive therapy instead of a defined duration therapy?
So, I think it depends on what you're calling high risk. So in my opinion, the only high risk factor in today's world is del 17p53 mutation. Even the complex karyotype, which was a high risk feature, but if you look at the recent data from CLL14, if you look at the Alliance study, complex karyotype in the frontline setting, as well as a recent update of Resonate study, the original Resonate study in relapsed refractory CLL, complex karyotype has no relevance. So in my opinion, I think the only bad high risk marker in today's world is del 17p53 mutation. So if you're talking about that very specific group of patient, then I would say that based on the slide I showed you from the CLL14 from ASH, which was actually when I was in the audience and looking at it, actually I was in the podium looking at it because I had a presentation in the same session. And I was like, oh, this needs to be looked at closely, because you see that those patients are relapsing after stopping ibrutinib at 1 year. How will it change my practice? So I think if I have a del 17p patient, when they reach 1 year mark, if they are MRD positive, certainly I'm going to continue their venetoclax. Even if they're MRD negative, if they're del 17p, I would be worried that this patient may relapse and I may elect to continue venetoclax longer. I don't know what the right strategy there should be, but that I think what I will do right now based on what I know.
Great. Another question is, if you have a young patient, ibrutinib, venetoclax versus IFCG, what would you select?
Oh, so that's a good. I mean, so I think both the options. So at least in our practice here, ibrutinib venetoclax actually right now is not FDA approved for patients with CLL. So it's not really available outside of a clinical trial setting. I think for young patients who are mutated, I do think that IFCG has a role, and given the data I showed you, I do discuss both the options with the patient. So the options I discuss with the patients is IFCG, standard of care ibrutinib, standard of care acalabrutinib, or standard of care venetoclax or obinutuzumab, because those are the 3 FDA approved regimens, and IFCG. And this is only I discuss if the patient is mutated IGVH patients. And then I would say that there are patients who do not want to receive immunotherapy, and they would say, no, thank you very much. I'm not going to get chemotherapy, and I'm taking the new drugs, which is fine. But there are patients who really think of this as a time-limited option, and then the long-term results, which has been very favorable for FCR with mutated patients, and they really want to look into that. But more and more, I mean, as you would think, at least in the United States, patients are moving away from chemotherapy. They don't want to get chemotherapy for CLL.
When you talk about the ibrutinib and acalabrutinib, you're showing the both options. So why the patient will choose ibrutinib over acalabrutinib?
So I list them. Generally, I write on a piece of paper with the patient in the room, and So I tell them what all are the options, because to be very honest with you, acalabrutinib is relatively new to the market. Most of the time, the patients who are coming to us, they're coming for second opinion, and they most likely they have read about, or their doctor, local doctor had mentioned about ibrutinib. So I do mention these ibrutinib, acalabrutinib, and venetoclax obinutuzumab. I can tell you that in my practice, since acalabrutinib has been approved, I have not prescribed ibrutinib. I have relied on acalabrutinib because of my experience so far with acalabrutinib. And I had few patients, I have 4 or 5 patients in the early phase 1 study of acalabrutinib who now I have been following for 4 or 5 years, and they're all doing well without any side effects. So the pros and cons are there, but I think in my experience, I'm favoring more acalabrutinib than ibrutinib. And then the choice becomes for the patients become whether they want to do that, which is a lifelong therapy or indefinite therapy, versus venetoclax G, which is a 1-year therapy. I would say most patients in my practice are choosing venetoclax obinutuzumab because they like 1-year therapy, they'll be done with it, and they have that feeling that they're done. Their cancer is cured, or what do you want to call it. So they feel good about it. And 9 out of 10 patients, I think in the last 1 year, I think have gone for venetoclax obinutuzumab in the frontline setting.
I think from there we move on to the questions related to MRD. So someone wants to know, is MRD negativity should be the primary endpoint for clinical trials?
So that's as an increasing, and it's becoming increasingly a question. So certainly all clinical trials these days are reporting MRD status for our patients, whether it's a primary endpoint or not. But I think increasingly FDA and EMA, European Medicine Agency, at least the EMA has recognized MRD as an endpoint for clinical trials. So, I think everyone, we know that if you are MRD negative, either in the blood or the bone marrow, and if you're a CR or a PR based on the lymph nodes, it doesn't really matter. Your progression-free survival is the same. And there has been some discussion in the groups and things like that, that maybe this CR/PR designation really is not valid anymore. And what really should be monitored is MRD for response, and that's pretty much it. And so I think eventually, who knows, things may change in future, but yeah, so certainly I think MRD is becoming more and more important, and it's being used in some trials as endpoint as well.
Great. So I think something related to that when ibrutinib was launched, there was a terminology of MRD with lymphocytosis. What's the current stance? Because most of these patients were not undetectable MRD when they were tested, for UMRD. So is there a change? Yeah, please go ahead.
Yeah, so I mean, I was just kind of clarified that the response was partial remission with lymphocytosis, not MRD with lymphocytosis, because with ibrutinib you will never practically get MRD negative remission. So with ibrutinib you will always have disease in your blood or bone marrow if you do an MRD with a sensitivity of 10 to the power minus 4. Same thing would be true for acalabrutinib. So the designation was partial remission with lymphocytosis because of this reactive lymphocytosis which is seen, which is still a designation. If you are doing clinical trials with ibrutinib alone, certainly you have to rate your patient or grade your patient as PR with lymphocytosis. But MRD with lymphocytosis will never happen because, first of all, MRD will practically never happen with ibrutinib. So there is no question of MRD happening with a white count of 100,000 with lymphocytosis.
We'll just take a few more questions before we end.
Sure.
So just a few practical questions. So how often do you vaccinate? Whether you vaccinate somebody in CLL who's going to be starting on ibrutinib, and if yes, how often do you revaccinate? And on the similar line, that if the patient is on, ibrutinib requires anticoagulation, which, oral anticoagulant you would prefer?
So regarding the vaccination, I would say we don't have a prospective program in our center that, oh, everyone has to be vaccinated at a certain time. So what we do, I think the two vaccinations really, I mean, one is the yearly flu vaccination, which all these patients, at least in the US, get or should get. And then the pneumococcal vaccination, which is generally every 5 years. I would say, at least in my practice, and maybe it's right or wrong, we don't really vaccinate patients and then start a ibrutinib or anything like that. Maybe we should, but we don't. We basically start the ibrutinib, and yes, if they need vaccination, it is true that they will have a less response to a vaccination if they are already on a BTK inhibitor. Um, but again, we have not proactively looked at in our center in that sense, and we have, and I'm not sure, to be very honest with you, if there are any specific guidelines in that regard. Um, and so that's what we do. So we are, I guess I would say that we are not very proactive in terms of looking at vaccination and the use of ibrutinib for our patients. Regarding the question of anticoagulation, that obviously is a major question in the field. Comes up quite often, actually, certainly with atrial fibrillation. So I think Eliquis, one of the newer oral anticoagulants, I think would be appropriate. Most of the time it's Eliquis, sometimes it's Xarelto. I don't know if it's one is better than the other. There are some studies from outside groups which have suggested maybe Eliquis is a preferred one. We are actually actively looking at this question in our database right now. Actually, only last week we were discussing it. We have a close to 1,000 patients, as I mentioned to you. So we are trying to really have a deep dive into all these patients to see their doses of ibrutinib, the bleeding complications, and then what kind of anticoagulation they were on, if they were on aspirin, and whatever they were on. So hopefully we'll have some answers from our large database in this regard.
Three questions which I'll sum up in one line is what sequencing you would prefer with all these options being available? What do you do in BTK resistance? And whether you can re-challenge these patients, especially with the defined duration of therapy, whether you can re-challenge the patient at relapse at later date with the same agents.
Yeah, so so just to kind of BTK resistance, I didn't touch on it just because I was wanting to focus on the frontline data. Certainly BTK resistance is an emerging issue for the field. With ibrutinib, what has been described with BTK resistance is development of C481S mutation, which is practically present in 80% of patients who relapse on ibrutinib. So it's a quite high number. So at our center, we have the assay for the BTK mutation. So certainly we check for it if a patient is relapsing or there comes suspicion of relapse to see if we can detect the mutation for these patients. And then only if a mutation is present, we really try to think of them as relapsed on BTK and then try to look for other treatment options for those patients. Coming back to the question of sequencing, I think really I think the obvious sequencing, in a way, if you're moving away from chemotherapy for all your patients, would be how naturally the drugs were developed, because ibrutinib came to the market first. So you will have data where patients are getting ibrutinib as a frontline therapy, and then they get venetoclax as a second line therapy, and then maybe a PI3 kinase inhibitor as a third line therapy. And around the same time, transplant and CAR T will be kind of in that kind of an order. Now, the reverse may be because now venetoclax is also available in the frontline in the US. So one could argue that, hey, why don't we start a patient on venetoclax in the frontline therapy? And if the patient were to relapse, can we salvage them with ibrutinib or acalabrutinib? Now, there is not much data out there of ibrutinib or acalabrutinib after venetoclax, just because CLL14 was just brand new last year. So not many patients have been treated in the US and elsewhere outside of a clinical trial setting where patients had venetoclax as their first line therapy, and then they're failing and they're going to ibrutinib. So unfortunately, not much data out there. But I would just say that, in my opinion, because the mechanism of resistance is different. For ibrutinib, resistance is a BTK mutation. With venetoclax, resistance is a BCL2 mutation, also increased expression of MCL1. So preclinically, if you look at the preclinical models, there is no cross resistance of ibrutinib or acalabrutinib to venetoclax or vice versa. So I would think that the use of a BTK inhibitor post venetoclax, it should work. I don't see any strong reason from what I know that it shouldn't work. Again, certainly we don't have data in that sphere. So for me, practically speaking, what is happening, as I mentioned to you, just last 1 year, majority of the patients, or a lot of patients, are getting venetoclax in the frontline setting. No one has progressed so far, but when they progress, I would certainly be looking at a BTK inhibitor-based therapy as the next salvage, and then start thinking about if they were to relapse again, or if they are young patients, especially with del17P, start thinking of transplant for these patients, or CAR T option, depending on the availability of those trials.
Great. I think we take the last question and we close the session. So the question is, if you have IGVH mutation and 11q deletion, whether you would recommend ibrutinib or other drugs?
So, so that's a very good question. So now one thing I would say, that will be a rare patient, because almost 90% of the patients who are deletion 11q will have a IGVH unmutated status. So it's hard to find a patient. It's rare to find a patient who is IGVH mutated and is deletion 11q. I think if that's a patient, I think, I don't know the right answer here. You could go for chemoimmunotherapy based on the mutation status, or you can go for ibrutinib, because as you may know, actually, if you look at the cytogenetic profile, the FISH profile, surprisingly, and so far I don't think we know clearly, ibrutinib and acalabrutinib looks really beautiful for deletion 11q. Actually, deletion 11q is the top line. So in terms of the PFS curves. So I think in that patient, in that situation, I think, I don't know the right answer, but I think I would be fine either way. You want to approach the patient, either with the chemoimmunotherapy or a target therapy, but that will be a rare patient to have.
Thank you, Nitin. That was really a brilliant session. You dissected all the data with so many options, giving us insight into what's best, which can be done in our setting, as well as if you have everything available to you. Dinesh, any concluding remarks before we allow Nitin to go back and sleep?
Yeah, it's 11:40 here. It's 11:41 nighttime.
You're going
Close
to
to
sleep,
midnight.
or you're going to some other trial?
No,
You're
no,
going to
I'm going to sleep now. I need to go to work tomorrow morning.
Okay. I'm sorry I couldn't. I really missed out the first part, but I'm really thankful to Nitin and the audience says Manju, Vikram, that we have a good session. In spite we had to push Nitin to that far, and he has to go on the work tomorrow. So thank you, Nitin. Thank you, everyone.
All right. Thank you, everyone. Thank you for listening. And as I mentioned, I think someone texted, or at least I see on the chat box here, to email the slides. I'm happy to email the slides, or maybe if the HCC folks or Manju or someone wants to email them, I'm fine with sharing the slides. Or if you email me directly at my email address, I can send you the slides.
So,
happy to do it.
Nitin, with your consent, what we are going to do, we are going to use your slides and put it up on our website, if that is okay with you.
Yeah, sure. Absolutely. Yeah, happy to.
Thank you.
Perfect.
Good
All
night.
right. Yeah. Good night, everyone, or good morning to you guys.
Bye.
Bye.
Good night. Thanks,
Thank you.
Nitin.
Bye.
Bye.